And again, greetings, welcome. Thanks for joining us here at the Robert Wood Johnson Foundation Systems for Action Research Program. You have tuned into our regularly recurring Research in Progress webinar series where we feature research projects that are funded through this program, give you a chance to get some early insight into research underway, all focused on how to best align medical, social, and public health delivery systems in ways that can improve population health and advance health equity. My name is Glenn Mays. I'm a professor at University of Colorado School of Public Health, and I have the pleasure of leading the National Program Office for the Systems for Action Research Program. If you're new to Systems for Action, thanks so much for joining us. You might be interested in browsing our website to get a better understanding of the research that's underway through this program. We've now have more than 30s underway, or some even completed now in this portfolio. We're a research program, and we're interested in testing novel ways of helping medical, social, and public health delivery systems work better together to advance health and health equity, particularly in light of all that we know and are still learning about social, economic, and environmental determinants of health, and our need to intervene productively and often simultaneously in all of those different drivers of health to make progress in improving health equity. Today, we're very fortunate to have one of our new cohorts, one of our newest cohorts of research projects join us today, give us a real early peek into this new study and what it will be doing. And this study, as you can see, is examining social bonds, a financing mechanism as a way to address social drivers of health equity. This study is led by a really talented group of people based at the University of Minnesota. Let me briefly introduce the flow of show and our speakers for today. Just in terms of for logistical issues, I'm going to introduce our speakers. We'll hear from them, an overview of their research. We'll then, as we usually do, have a commentary from someone who's connected to this research. And then after that, we will open it up for a Q&A session. We welcome any of you who are with us in the webinar today to submit your questions. We'll try to get to as many of those as we can during the latter portion of this hour. If you're, hopefully you're with us on the web in the Zoom meeting, and if so, we invite you to submit questions at any time using the Q&A box that is should be located down at an icon down at the bottom center of your screen. Click on that Q&A box, type your question in there, and when we get to Q&A, we'll get through as many of those as we can. So with that, let me introduce our speakers for today. Professor Pinar Karaca-Mandic, and I apologize for any mispronunciations on names. But Professor Pinar Karaca-Mandic leads this research team at the University of Minnesota. She's a professor in the Carlson School of Management there at University of Minnesota. A long track record of research, especially in the health economics and healthcare financing arena. You can read more about her background and research on this page. We'll be hearing from her and then several of her colleagues who are a part of this research team, including Dr. Raoul Qurani, who is president and CEO of the Minnesota Hospital Association, also a long and distinguished career in hospital and healthcare management and leadership. We will also be hearing from Dr. Nathan Chamillo, who is medical director for the state of Minnesota's Medicaid and Minnesota Care programs, and is also in his clinical work, practices as a general pediatrician with Park Nicollet Health Services and the Health Partners Health System there in Minnesota. Also, really impressive record of both clinical and health policy work that he brings to the project as well. So, as usual with these projects, we have an interdisciplinary teams of leaders and innovators and investigators to make this work happen. So, with that, I will turn it over to our team from the University of Minnesota.
Thank you so much, Glenn. If you would let me share my screen, I can take the presentation from here.
Absolutely. I think you should be able to do that.
Okay, is that okay now?
Perfect.
Excellent. Well, thank you so much. First of all, before I start, I thank Robert Wood Johnson Foundation and the Systems for Action program very, very much from the very early stages of when we started talking with your team, just bouncing off ideas and understanding, attending your webinars, and as we were proposing and putting together this idea, and we're very grateful to be one of the funded teams. As Glenn mentioned, what you will hear from us is a very early stage. We got funded mid-November, and we are very interested in thinking about the brand new, very novel financial instrument that we would like to design, which we are calling a social bond. And our goal with that is to pool resources across multiple competing health plans in order to create a stable long-term financing for the interventions that actually address social drivers of health. Before I go any deeper, just the key features of what we are trying to do here is we are focusing on the Medicaid population, and I'll tell you more about that in a bit. The idea we are proposing is to allow multiple health plans participating in the Medicaid program as Medicaid managed care organizations, or you will hear me say MCO throughout the presentation, to collectively issue and administer a bond, like a savings bond. And along the lines, we will also be able to investigate the role for a public-private partnership, perhaps allowing the state Medicaid agency or another public health agency to participate as one of the issuers of the bond. When the bond raises funds from just individual investors, just regular people like you and me, these investments will then go into community-based organizations and other interventions that address social issues such as food insecurity, housing instability, transportation, structural racism, among many others. And the idea is that as these interventions result in healthcare cost savings, because they're going to be improving people's lives, then these cost savings will be then used to pay back the investors with interest. So the problem that we are trying to solve, as this audience here is very closely familiar with, the social drivers of health, SDH in abbreviation, such as structural racism, food insecurity, housing insecurity, instability, education, transportation, and many, many other dimensions. These factors we know shape the well-being and health of individuals, and we know that they impact racial and health equity. And at the same time, we know that they drive a very large fraction of healthcare costs because they result in avoidable adverse outcomes such as hospitalizations, ER visits, etc. Recently, both the federal and state initiatives, as well as a growing number of hospitals and health systems and payers, are recognizing the importance of SDH, and they have programs and initiatives addressing them. However, they tend to typically stay in silos rather than through a designed implementation with a coordinated, sustainable, scalable model. We know that the community-based organizations, social services organizations, and other public health programs are actually very well positioned to address some of the SDH needs of their communities. They're very connected to their communities, but the fundamental problem is that they tend to be underfunded, they lack sustainable funding, that makes it very difficult to scale up some of these STH interventions and to offer them with a continuity, which is really very important in the way that for them to achieve the outcomes that we desire. So what we end up saying then is that there is a very critical need for innovative financial systems that is going to enable some of the efficient and sustainable funding for these projects that drive social drivers of health. I would like to invite my co-PI, Dr. Raoul Qurani, who is the CEO and the president of the Minnesota Hospital Association, to also reflect on this point from his perspective. Raoul, if you could join us.
Thank you, Pinar. So as Pinar said, we are starting to think about how there can be more and more collaboration between the financing arm of healthcare and the delivery arm of healthcare. I think many of you or most of you may know that due to employment reasons or other drivers, the individual or the family sometimes may switch insurers. And in insurance or payer industry, that's called churn. So a particular individual or family may be financed through a particular insurance company, but they may switch that due to relocation or job changes, and they may or may not switch their primary care clinic. So part of the philosophy of this is also to think about, just like we do in healthcare delivery, a continuity of care. So through primary care, through hospitalization, through community-based services, there's a continuum of care and a continuity of care throughout the patient's lifetime. We're also trying to think about how can there be a continuity of financing so that there can be a ROI that can be calculated from the financing arm as well. So, and again, as Pinar said, there's increasing and thankfully increasing attention to inclusivity, diversity, equity issues in healthcare, just like in other aspects of our society. Again, many of you, or hopefully all of you, listened to the president's speech last night. And again, it's clear that the federal government is prioritizing this. We are seeing this here in our state, in Minnesota, with the state government. So working on social drivers of health, including structural racism, including instabilities in housing and transportation and food, medical health literacy, all of those are directly impacting the individual healthcare, individual health, families' health, community health, population health. And this project is really exciting so that we can start thinking about how we can have continuity of financing so that what the payers do in service of those whom they cover can actually benefit that individual, but also the entire community.
Thank you so much, Raoul. Thank you. So as our project focusing on Medicaid, we chose to focus on Medicaid for several reasons. Of course, in addition to covering over 70 million individuals in the US and accounting for 20% of healthcare spending, Medicaid patients tend to have very complex conditions and extreme SDH complications that really interfere with their ability to adhere to care as well as their well-being. And as such, the impact of addressing these needs to improve racial and health equity is significantly elevated in the Medicaid population. And in addition, state Medicaid programs have tremendously actionable policy levers and flexibility to address some of the SDH needs of their communities. Based on some of the data from 2019, for example, 40 states were working to address the social needs with a wide range of activities through either their Section 1115 demonstration waivers or some managed care contracts. For example, 32 of the states had MCO contract requirement to have at least one SDH strategy. 28 of them required referring enrollees to social services. 25 of them required screening individuals for social services, and 22 required the MCOs to actually partner with CBOs and social service providers. So there is tremendous lever that Medicaid can actually play in looking at this idea to provide this, coming up with a model that can allow for sustainable financing. As our project team is based in Minnesota, along with all our community partners, I also would like to give a little bit of a context on Medicaid in Minnesota. Recently, a new report came out from our Minnesota Department of Human Services, and Dr. Chamula may also reflect on that later on during his commentary, titled Building Racial Equity into the Walls of Minnesota Medicaid, a focus on US-born Black Minnesotans. And this was a February 22 report. And one of the important points that this report says is that Medicaid is an important source of access for a lot of our minority populations. In 2019, Medicaid was the source of health coverage for 41.5% of Black Minnesotans, 39% for 41.5% of Black Minnesotans, 39% of American Indian, Alaska Native Minnesotans, and 29.5% of Hispanic and Latino Minnesotans. Unfortunately, while Minnesota may be one of the highest quality of life states, primarily for white Minnesotans, that doesn't happen to reflect to our entire community. And it's also one of the worst states in terms of the health of Black individuals, Black communities. In fact, one of the University of Minnesota economists, Dr. Samuel Myers, termed this the Minnesota paradox. And how can we have this great quality of life overall, but such significant disparities across all these dimensions? For example, we are the second biggest income inequality gap between Black and white people in the entire nation. Similarly, we are one of the widest home ownership gaps, again, and more than double food insecurity reported by Black and Latino Minnesotans relative to whites. And again, something else that this report makes a really important point is that Minnesota Medicaid has some of the key levers to be able to change this. And it's through eligibility and enrollment, through access, quality, as well as other early opportunities such as prenatal, maternal, and other early childhood programs. And that's really what we are really leveraging as a team here, and our state's commitment, the Medicaid commitment in Minnesota. All right, let me move onto describing the particular wrong pocket problem we're trying to solve in this project. And my colleague, Dr. Qurani, also talked about it a little bit. So from the perspective of a Medicaid managed care organization, Medicaid MCO, receiving capitated payments per enrollee, thus they're at risk for medical spending, addressing the SDH needs of their enrollees actually has a very robust business case, right? Because if you address the SDH needs, you are reducing those downstream avoidable hospitalizations, and the payments that you will incur are going to be lower. Like addressing the food insecurity of a diabetic enrollee, it is going to improve the access to healthy food and nutrition, and will likely result in reduced diabetes complications down the road. But we also know that it often takes a long time for SDH interventions to result in health improvements over a long period of time. It's very similar in some sense to some of the preventive care dilemmas that we have, that the returns accrue over a very, very long time. And thus the return on these SDH investments by a given Medicaid managed care organization is realized in the long run as cost savings. However, there are two key reasons from the perspective of our team that these future returns are not guaranteed for the MCO that is actually making the investment. And one of them is, as Raoul said, Medicaid is characterized with actually very volatile enrollment patterns and coverage changes, which is what we refer as the churn rate, with monthly changes in eligibility, people going in and out of Medicaid, disruption of coverage, changing plans when they come back in voluntarily and involuntarily. The second reason is we know that the Medicaid contracts are allocated with a competitive bidding process in many of the states where we have Medicaid MCOs. And so to the extent that this competitive bidding process kicks in every now and then, 3 to 5 years, a given Medicaid MCO may lose their contract in a given area, may lose their annual lease to another Medicaid MCO. And thus what happens, bottom line, is that some of these investments, the future benefits from some of these SDH investments in terms of cost savings by one MCO accrue to other MCOs or outside of the managed care system. And in economics, we actually talk about it in terms of either the free riding problem or the positive externality problem. But the result, the end result, theoretically and empirically, is that there is insufficient SDH investments from an economic efficiency standpoint. We have inefficiently low SDH investments because the given MCO is not able to realize full returns of their SDH investments. So what we say is, how about then the MCOs then jointly invest in SDH of their joint pool of enrollees? So in fact, when we started thinking about it, one of the things that came into our mind as the study team was that, well, how about we ask MCOs to invest X dollars today, and they all invest X dollars up front, and then the funds are raised. Of course, I mean, that's one idea, but then when you think about implementation challenges, how large is X? Can the MCOs really commit to that large expenses up front? What happens when enrollees switch from one MCO to another with the same idea as the churn? How are those benefits, like returns, calculated? And so we have not yet solved the wrong pocket problem with that approach. So our proposed idea is then to actually go to the market and say, let's raise funds in the market through a savings bond that can be jointly issued by multiple MCOs. What a bond is, it is a financial contract that is sold by an institution, and that institution could be a company, government. In this case, what we're saying is multiple MCOs together. The bond is sold to the investors. Investors buy the bond for a certain price, and then this institution gets funds. And in exchange, this institution, so this joint MCOs, are going to promise to pay back to investors some money in the future. They'll pay the principal and some interest, and that future time, which we refer to as the bond maturity. And because this is not what we're proposing is a jointly issued bond, what we're saying is that these promised cash flows back to the investors are going to be split between the MCOs, and that in fact, they will be easily calculated based on the share of the cost savings that will accrue to each MCO. And that is going to solve our wrong pocket problem. So let me elaborate a little bit further on this. So again, what we're saying is that the bond will be issued jointly by multiple MCOs. And in fact, what we're exploring is a legal entity called Special Purpose Vehicle, or SPV in short, that exists, that we can set the bond in this SPV mechanism. And investors buy the bond for a certain price and the funds are raised. So to illustrate with like a simple example, let's consider that there are only two MCOs, MCO A and MCO B, that serve the Medicaid population in a particular geographic area. Let's say that A and B jointly issue the SPV with the maturity in a future date, let's say 5 years. Individual investors, again, like regular people like you and me, we buy this bond. And what makes this a social bond is that then as an investor, we know that the proceeds will then be used to fund SDH projects, such as those that are going to address people's housing needs, their food insecurity, and programs targeted to ending racism. And so that these programs, that's why we know that the proceeds will go to these social cause types of projects. So as then the enrollees benefit from these SDH projects that they receive, then their health will improve, cost savings are going to be realized, and when the bond matures, I believe we said like in 5 years from now, MCOs will now have to pay back to the investors. Again, our idea here is that the MCO is going to pay back to the investors proportional to their estimated cost savings. So that if as enrollment moves from A to B, let's say A loses their contract bid in a given area, or vice versa in the future, the responsibility for making those payments to service the bonds can be reallocated over the specified time periods. That way, for example, if a significant share of the enrollee population departs A to enroll in B in the future, the proportion of those outstanding bonds to be serviced by A also decreases. And again, that's how we're going to solve this wrong pocket problem. There are many problems that we think that this bond mechanism is going to solve. The first thing we're doing is that we're harnessing the power of the broader capital market. We're bringing in socially minded individual investors directly, allowing the funds to be raised quickly. We're not asking for MCOs to upfront large sums of money. The money is coming from individual investors. The second thing we're doing is diversification and risk pooling. We're pooling funds and then we're able to invest across multiple SDH projects for a large group of individuals, because the way we envision is that when the funds are raised by, say, MCO A and B, the projects that the funds will actually support will be available to all the enrollees of A and B. So we are allowing for this risk sharing across different MCOs, coupled with the future cost savings benefits. And we're also allowing for continuity and patient access. As Raoul said, we're really interested in continuity of financing. As we talk about continuity in medical care, we need to emphasize continuity in social care. So we're allowing programs to be accessible to people, even if they move from one MCO to the other, because the bond is there to fund the joint enrollee population. So in a way that the bond is following the patient, which allows for tracking the beneficiaries of the SDH programs, which will then be really important for us to create a mechanism to calculate what % of these outstanding bonds need to be paid by the MCOs. The other thing that this mechanism allows for is significant role for public-private partnership. The state Medicaid agency, it may want to subsidize the bond or back the bond in exchange for supporting some SDH projects that may not have a large financial return, thus may not be as interesting and attractive to individual investors, but such projects may have such important health equity and racial justice impact that the state Medicaid agency may want to be part of this and subsidize. So in terms of our study aims, we have two broad aims in this project. One, we want to design and prototype the social bond. We want to identify some of the key parameters and features of this bond. Like you heard me refer to like maturity, right? Is it 5 years? Is it 3 years? And we will be doing that with stakeholder engagement. We want to be able to figure out the return on investment on the SDH programs that we think we can achieve, but assessing returns on two domains. One of them is the economic returns in terms of what kind of cost savings investing, say, in food insecurity will result in. But the other one is health equity and racial equity impact. Once we invest in certain programs, to what extent are we moving the needle in terms of addressing health equity and racial equity? Second aim is that we want to evaluate the performance of the SDH interventions funded by the social bond, and we can do that using simulation models. And I'll tell you a little bit more in a minute, but what we are thinking is from aim one, we will be informed with the type of projects that this bond could support, the funds from the bond. And so we will create a hypothetical portfolio of SDH interventions and projects. And then under alternative scenarios, we can figure out the exact kinds of cost savings and the exact kinds of returns that this can bring back to investors to see whether this is a feasible project or not. In terms of our methodology, again, we are taking a community participatory approach in the sense that we are engaging with local health and social service stakeholders to design this bond instrument. We are doing literature searches, both to peer-reviewed literature as well as gray literature, but at the same time, we will be looking at some qualitative data collection through key informant interviews and focus groups to assess and understand the returns of multiple SDH initiatives in Minnesota as well as nationally that we may have seen, or that our stakeholders may have seen, again, in terms of both economic returns, in terms of cost savings, but as well as health equity and racial equity impact. Once we have that, we will create a taxonomy of the types of different initiatives to be able to select which hypothetical STH projects we want to simulate. And then we can do Monte Carlo simulations on the bond's impact on health and social outcomes, returns, while also estimating returns to Medicaid and health plans and other investors. Again, as I mentioned, the stakeholder engagement in the bond design. How do we set up the bond? What are some of the technical features? We are talking about the special purpose vehicle as a feature. What are legal frameworks? What are standards? What do we think about maturity? Some of the bond terms like interest rate, coupon rate, do we pay back to investors on a frequent basis, or do we pay them all at the end in 5 years or at the end of 3 years? What are some of the implementation challenges? Again, in terms of these STH initiatives that we may have seen in the marketplace in nationally or in Minnesota, whom did they serve? What impact did they have in health equity and racial equity? What were some of the outcomes that were measured? Say there were changes in food insecurity, to what extent, changes in hospitalizations, and how do those changes translate to certain cost savings? So we started doing some preliminary literature review. Again, this is a fairly new project at sort of mid-November onwards. And so the Siren network out of UCSF has been super important and useful for us to look at. This is just 3 domains that we search, food and hunger, housing stability and transportation. We start with 330 articles peer-reviewed, say for food and hunger, but then when we narrow it down to the kinds of articles that actually talk about utilization costs, we significantly lower that number to 56. And then as you can see, we have about 10 in 2019, 11 in 2018. So we're kind of reviewing that. In addition to these individual articles, I think one thing that has been really interesting and useful were these sort of meta review kinds of articles, like the National Academies of Sciences, Engineering and Medicine. They have a proceedings of a workshop that they published talking about the evidence both on peer-reviewed literature and gray literature. Similarly, the Commonwealth Foundation has several initiatives just reviewing the evidence for these health-related social needs interventions. And really, there are gaps, and we expect gaps to happen. But as we read through and synthesizing this information, there is really good evidence out there about financial returns. Like in housing, for example, different studies are looking at stable housing after discharge, after recovery, affordable housing, primarily to homeless and Medicaid population, and reporting about 30% reductions in hospitalizations, and ROI of $1.57 for every $1 invested. That there's of course a range. For some of the food interventions, there are studies that looked at medically tailored meals, Meals on Wheels, SNAP benefits, fresh food pharmacies, and again, a lot of different populations, the duals, patients with diabetes, patients with other chronic conditions. And again, ROI ranges like 77%, 100%, even 250% ROI being reported by some of these studies. In addition to the literature review, again, then we are seeing a lot of what we may call gray literature or pilots and interventions that are happening in the real world through different payer and provider organizations. This one here, America's largest health insurers giving apartments to homeless people, that's actually United Healthcare initiative. You have initiatives from Geisinger with a fresh food pharmacy. Again, why are hospitals getting into housing business? And Humana's Bold Goal, Blue Cross Blue Shield with RX for Healthy Living. So there's a lot of interventions out there, and that will be part of this key informant interviews where we get more in depth in how these interventions worked. Why did they work? Why didn't? What were the opportunities and barriers? All right. So let's say that we have collected all that information, hopefully we will. And so the next step after we do that is that we will sort these programs and we'll create a methodological taxonomy of the programs. And that will happen through our stakeholder engagement and our research team, focus groups. And we want to sort these programs along 2 dimensions. The first dimension is financial return, right? We want to assess the likelihood that each of these programs are moving ROI, they have positive NPV, or, you know, that they're associated with these projects that they wanted, the outcomes that they wanted to achieve. And then we will get some of these outcomes. Sometimes maybe the study will not report cost savings, but it will say, okay, the food insecurity reduced by X% among the people who benefited this program. And then we could use some data analysis and the literature, estimates from the literature, and data like medical expenditure panel survey to try to convert this. What does reduced food insecurity by X% mean in terms of changes in healthcare costs? So that's sort of where we will be working on assigning some financial return. But the second very important dimension that we're going to be sort of ranking or kind of scoring these programs that we find is the extent to which the project is impacting different racial ethnic groups and with a potential to reduce health inequities broadly. And there are several toolkits available in this domain that the 2 that I report here, the Racial Equity Impact Assessment Toolkit, as well as the Government Alliance on Race and Equity Toolkit. These are toolkits that are developed, designed to systematically evaluate how a proposed action, a policy action, may affect different racial and ethnic groups. So we will be working and learning and working with these toolkits to construct a methodology to score these SDH projects in racial and health equity dimensions. And then we're going to map them out like this. So we are going to have these projects on the social domain with the social, let's call it the social ROI. And then we will have some projects on the financial domain. If you look at it, the quadrant one is the types of projects that are returning ROI, both on the financial, high ROI, both on the financial return and social return. So we're going to start with these projects and we are going to run them through our bone simulation. And we're going to see the amount of social return, social ROI, as well as the financial ROI that we get. Then what we can do, which is really exciting, is that we can start saying, well, great. So these are high financial return, high social return. But how about we look at quadrant 4, where we have the types of projects that are really high in terms of social return, in terms of the health equity and racial justice, but they don't really move the needle on financial return. And then we're going to estimate the performance of the portfolio again. And we will look at the difference. And the difference is actually going to allow us to quantify the role for public and private partnership. We will know that once we start planning in projects from quadrant 1, the financial return is going to be lower, right? And so that is exactly the kinds of subsidy we may need to think from the public sector and say, this is the amount of subsidy that is needed to implement more of the quadrant 4 projects that don't have the financial return, but they're so important in terms of addressing health equity and racial justice. Then we can do these, exercises under alternative bond features and structures. And this will, again, be very much informed by our stakeholder engagement. We can vary this maturity structure, say, to 3 years, 5 years. We can think about, do we pay back to investors annually? How much? Or do we just wait until the end of the maturity? And there are other structural features of the bond and frameworks and things like that. The other thing is that our baseline scenario is looking at a purely private structure with the multiple MCOs, going with the special purpose vehicle mechanism that is owned by the MCOs. We can vary the number of participating MCOs and their enrollee population. We can look at this public-private partnership model, for example, a government-backed social bond, where some of the losses may be covered by a public entity. Another thing we can do is that, like in our baseline, again, the investors like you and I, we don't have any risk. We are going to buy the bond. We know our money will be used for social projects, so we will expect our return. All the risk is actually borne by the MCOs, because what they're getting in is that they will realize cost savings, and those cost savings will be used. But in an alternative scenario, we could definitely think about some of the risk and return to be shared with individual investors. For example, investors can receive a higher risk in the sense that they receive a return only if certain predetermined outcomes are reached. And that is sort of, you may have seen it in the literature as social impact bonds, which as payment is conditional on certain performance metrics. So kind of coming to the end of my talk, but the one thing I do want to say is that this idea that we have is actually is relevant for a relatively new but a very emerging area of finance. There's a lot of interest in increasing attention to what is called the environmental, social, and governance, ESG, strategies for investments over the last decade. What is even newer is this idea of like the green bond market, and that was initially for specific environmental issues, but have been evolving into different variants. So some of the variants, the green finance bonds, these are broader than climate finance. They actually address other environmental objectives such as natural resource conservation, biodiversity conservation. Then there's sustainable finance bonds, which are incorporating this climate and green and social finance, but basically adding a stronger consideration considering longer term economic sustainability. Then there's social finance bonds, which are financing that supports actions that mitigate and address social issues, social and economic issues. So our actually project is directly embodied in this kind of work. And then the social sustainability linked bonds. These are basically the kind of the bonds that are financial or structural characteristics of the bond can vary depending on whether the issuer achieves certain predefined sustainability metrics and objectives. So overall, if you look at it, again, very new. For the full year of 2021, a total of $1.6 trillion dollars of bonds and loans were issued across all of these 4 different market types. But that is a huge increase from only 148 billion in 2016 over this last 5 years. And since 2020, with the pandemic, the attention to these sustainability-linked bonds have been fastest growing segment of the market, primarily in Europe through European government agencies. But very interestingly, new bond principles and guidelines are being developed. In terms of the next steps we will be doing in the shorter run, next steps, not our entire 3-year project, we'll be doing some of the peer-reviewed grade literature reviews, stakeholder interviews, that's in participation, collaboration with Raoul's team at the Minnesota Hospital Association. We'll be reviewing these social bond principles and standards and frameworks together with some of our stakeholders, reviewing and building our methodologies for simulation, and running some of these simulation models and starting to prepare our manuscripts. And this is our team. Again, I'm the PI for this project. My co-PI is Raoul Qurani, who's the CEO of the president of the Minnesota Hospital Association. We have Susanna Gibbons, who is the managing director of our Carlson Funds Enterprise, a student-run actual fund that Susanna manages for our MBA students. Our collaborator, David Haynes, is from the assistant professor in the Institute for Health Informatics. David is a health informaticist, health geographer, deeply involved in community-based research, community-based organizations, and disparities. Saya Nikbe, associate professor in the School of Public Health in the Health Division of Health Policy and Management, and Richard Takor, my colleague, assistant professor in the finance department here. And then we have Jennifer Schoenecker, who is the senior director of quality and safety in the Minnesota Hospital Association, and Joe Schindler, who is the VP of Finance and Analytics, Finance Policy and Analytics in the Minnesota Hospital Association, and my colleague Kimberly Choi, who is our program administrator in the Business Advancement Center for Health, where I just recently co-founded at the Carlson School, and Kim is our project manager. And we have 3 undergraduate research assistants who started working with us. And finally, these are our partners, stakeholders. Again, in addition to Minnesota Hospital Associations, we are grateful to have support letters and stakeholder engagement commitments from the Wilder Foundation, Minnesota Council of Health Plans, Minnesota Department of Human Services, Minnesota Department of Health, Piper Sandler and Healthcare Investment, Financial Services Company, Prime West Health, Second Harvest Heartland, Stratus Health, and Collective Action Lab. Well, thank you so much. And I think the next is I can stop sharing my screen, and then we have Dr. Nathan Chomolo, who will do a commentary. Thank you very much. And please reach out to us if you have any questions.
Yeah, thank you, Pinar and Rahul, for going over this work. And it's really, really interesting. And, I was excited to be able to support exploration of this model when you brought it to me, because the wrong pocket problem that you touched on, it really is real. And we know so many of the inequities that we see that lead to the disparities in our care have been built into our systems over generations. And it's going to take them generations to undo, yet our financial incentives that drive most of our system and even fund things like research really aren't aligned with this kind of longitudinal aspect. And you think about not only what the MCOs are looking for in their 5-year contracts, but as a state, what we look for in a 2-year budget cycle or a 4-year election cycle, it doesn't lend itself to some of these more longitudinal investments. And so I think a lot of the questions that I'm seeing pop up here are kind of, I have and continue to have about, where this will go. How are we going to ensure that the good intention here isn't corrupted by the demand for profits and returns, right? I think there was a question about this is basically crowdfunding, and how do you kind of then make sure that those incentives to get returns don't then overtake the intent here to address structural inequity and reduce racial and health inequity in particular, because those things aren't always mutually exclusive. Like we have inequities, right, because we haven't made the intent to invest in certain parts of our community and in certain communities in particular. And so sometimes to address those gaps actually takes just more investment, and that's not going to necessarily generate the savings that this model is hoping to capture at some degree along the way. I do think the continuity and patient access pieces help address some of that, right? That the fact that it follows the patient and that a patient can kind of stay in the intervention no matter who they're enrolled with. But it's noted it's still kind of crucial that a racial equity assessment tool is used to determine which populations and interventions are the focus. I really appreciate you kind of highlighting our report on building racial equity into the walls of Minnesota Medicaid, where we talk about how different populations really get access to their healthcare through Medicaid at different degrees in Minnesota. But if you kind of take a flip, and the way that we've traditionally looked at it is like, what our enrollees identify as, and within Minnesota Medicaid, only 3% of our enrollees identify as American Indian, only 7% as Asian Pacific Islander, only 10% as Hispanic, and only 18% as Black versus 51% of white. So if you're looking to structure for kind of an intervention that will, generate more return, just looking at those numbers, you could end up more likely going towards interventions that capture a wider range of our enrollees, which would predominantly be kind of our white enrollees, which do face, barriers to health, and particularly those who are Medicaid programs, but that wouldn't address necessarily the racial inequity the same way. And so how do we, ensure that there is that balance there? And then thinking about how we look for any adverse incentives or unintended consequences. If the bond payment is following the patient, could this lead to MCOs or even state agencies starting to restrict patients to certain MCOs to maintain any type of financial balance, even if it's in conflict with what the enrollee desires? And then I think there's also some questions about like, how are we engaging the broader community, and how will this tool promote broader racial justice, right? If a community-based organization or group devises the intervention that leads to cost savings and improved health, will they benefit financially as well? Or is it just the investors and the MCOs? You know, how can the capital gains be in part shared with communities that have historically been kept from this part of the economy? I think some of the questions that I have as we continue to go into this work. And I'll end on thinking about, just as a physician and my own kind of personal, you know, lens of how do I drive in every part of my life for racial and health equity. One of the things that we've talked about at Minnesota Doctors for Health Equity is, you know, your own finances. As a physician, you make a good amount. Average physician makes 4 times the median amount. So what are you doing with your 401k? And so we've been talking at Minnesota Doctors for Health Equity for over 5 years about things like environmental social governance strategies for your own investments. And so I think, you know, if something like this or other kind of social bonds can be realized, I think that would be really attractive for those of us who really want to see our own finances reflect our values and our commitment to racial and health equity. And then I'm hoping that our health systems will then, you know, have that as an option for all their employees, that our physician organizations, our large physician organizations that have, and all these other organizations that have made commitment to health and racial equity can then look at this as a way to have and direct their employees who are interested in investing their money in this way end up here. So I think there's a lot to bite into and a lot of great questions. So I'll kind of wrap up my comments there and look forward to hearing more and learning more along the way.
Thank you.
Fantastic. Thank you so much to all of our panelists and commentators from the Minnesota team. Really interesting work at the early stages of implementation, but you can see, I think we're all going to want to track as this project moves forward to see what we can learn from it. We've got a number of questions in the Q&A box. We've got 7 or 8 minutes to get through at least some of these, probably not all. I will say there's several questions just asking about how can we find out more information, or are there slides available, or is there other documentation? Let me tell you one place you can look. There is a page for this particular study on the Systems for Action website. And as this research team produces documents and publications and slide sets and things that are ready to be shared with others, we'll make sure to post it on the Systems for Action webpage for this particular study. So that's one place where you can always go to look for products and publications. So there's a question here about, you mentioned this kind of at this stage that you're using kind of a hypothetical bundle of SDOH interventions. In practice, how would the specific types of interventions be decided upon and phased in under the bonding mechanism? Any insights there?
That's an excellent question, and I would hope that that would be another Robert Wood Johnson Foundation project in the future. But that is something that we've, you know, of course, we're doing this hypotheticals in the sense that as we find out the ROI in both of these dimensions, both on the social and financial from the literature, we want to basically get a sense by simulating this bond under different hypothetical scenarios of hypothetical projects, like what are the type of cost savings, what breaks the bank versus what are some of the things that we can actually support, right? And I think this is just my personal kind of view. We haven't really sit together with the team to exactly discuss how this could work in the future. But the way I would envision is once the funds are raised from individual investors, that the community-based organizations, social services organizations, they bid their project, they submit their project, and we will by then have a mechanism to simulate this bond under different types of projects. And then we just kind of keep feeding the types of projects and optimizing across the projects that will be the winners to receive the funds. And then the projects will then be made available to all the individuals to ensure that continuity, regardless of whether you switch out of your MCO or not.
Pinar,
that's one way. Yeah.
I would just add to that, you know, Minnesota was one of, I believe, 7 or 8 states 7 years ago to get a federal state innovation model grant. And part of what we did with that was to identify which were the top social drivers of health that mattered to our populations. And again, it's the same ones that we've discussed today. It's race, ethnicity, language influencers. It's housing, transportation, insecurities. So that's one piece of knowledge that we will lean on. The other piece is that all the payers and the providers do community health needs assessments. So that's part and parcel of, especially the not-for-profit providers and not-for-profit health plans. So we have that body of knowledge too. And again, it will not be a surprise to any of our listeners today that many of those needs are similar. And we know them based upon those assessments that both the payers and providers do.
But the diversity of projects is going to be really important, and the diversity of food and housing and the way they meet the population needs. What is super interesting also, I think, here is that we know also from a lot of the literature that individuals have multiple of these needs. It's very often that, people have food and housing needs. And the fact that through a continuity of, services and investments and projects that we can address both, those are actually correlated positively in a way to even improve both the financial and the social returns. So that diversity of the project is going to be a key that we would have to look at.
Fantastic. Lots of good questions here. And I know we can't get through them all, but another one that comes up, what about interventions that may have returns outside of the medical care sector and outside of Medicaid, like, in mental health interventions that may have savings that accrue to the criminal justice system or to courts or to schools? Any thoughts about capturing those issues?
Yeah, I would, again, another excellent question. I would characterize that on that second domain, which is, the social return in terms of, that is occurring outside of some of the, it's impacting the society in positive ways that may not even have a direct financial return, but they may have both. They may have both the financial return and that. So definitely those kinds of projects would be very, very interesting and attractive ones, I would think.
I would just add, Glenn, to that many on this call already may know about the CMS innovation that they've been reflecting on and working on for the last many years, called the Accountable Communities for Health. That's where multiple medical, payer, and community-based organizations come together to pool their resources so that any value created in terms of real dollars is reinvested back into those community assets, delivery providers, but also roads and bridges and infrastructure and all of the other drivers and assets that a community needs to thrive.
Fantastic. One more question to slip in, an interesting question about how, for your simulation study, how will you attempt to estimate the potential uptake of this bond by private investors and issues of their risk tolerance and those kind of issues?
No, that's another very good, very good, consideration. One of those, I would call it under those alternative scenarios, right? And the extent to which our returns will vary by the size of the bond is something we can look at. The size of the funds raised is essentially what that uptake question refers to.
Absolutely. Fantastic. Well, we are at the top of the hour, unfortunately. Really interesting work, great discussion. Thank you again to the Minnesota team for sharing with us your research. We're going to look forward to see how this study plays out. Hopefully we can have you back in future editions of this webinar series to give us updates on your progress and what you're learning as you go. Thanks again to everybody for joining us. Again, this is something we do about every 2 weeks, featuring studies from the Systems for Action program. So please put this on your calendar. You can find out about upcoming webinars and other events, including upcoming funding opportunities. If you've got an idea for how to align medical, social, and public health systems, you can sign up for our newsletters and also keep tabs, all of that on our website. at systemsforaction.org. We always thank the Robert Wood Johnson Foundation for their leadership and support of this program, and wish you all a great rest of your day. Thanks
Thank
so
you
much.
so much. Thank you very much.
Thank you.